You good, MJ? Excellent. Good morning, everyone, and welcome. My name's Niles France, and I work at the Alzheimer's Association. Welcome to the Alzheimer's Association International Conference 2022, to both the people in the room and to those joining us on the Zoom call. This is our first of two news briefings, and the topic this morning is experiences of racism, cognition, and dementia risk. Letting you know, as of Sunday, we have 5,230 registered to be here in person and 4,228 registered to be here virtually for a total of 9,459. I will try to get you updated numbers if we have them by the end of the session. 58% of the registered attendees are female, 40% are male, 2% preferred not to answer. 60% are from North America and 40% from other places around the globe, representing 98 countries. Including posters and talks, there are more than 4,000 pieces of science being reported. The embargo on the material from this morning's news briefing is at the scheduled end of the briefing at 8 a.m. Pacific time. In your reporting, we ask that you please refer to the full name of the meeting on first reference, the Alzheimer's Association International Conference, and that subsequent references, of course, can be to AAIC. Each of our AAIC news briefings has a moderator who will introduce and wrap up the session and will also moderate the Q&A. That person is an Alzheimer's Association staff member and spokesperson and can be quoted as such. We'll do all four of our scientists and panelists' presentations, and then we'll do the Q&A at the very end. We'll take questions first from journalists in the room. You'll get called on from the podium. Please raise your hand if you have a question and wait for the wireless mic to come to you so we can hear your question and capture it also on the Zoom call. Please start with your name and the outlet that you're reporting for. Then we'll go to the Zoom. On the Zoom, you can virtually raise your hand to ask a question yourself, or you can type it into the Q&A function and it will be read by one of our staff. In all cases, again, please give your name first and the outlet that you're reporting for. Our moderator this morning is Dr. Carl Hill. Dr. Hill is Alzheimer's Association Chief Diversity, Equity, and Inclusion Officer. Dr. Hill.
Well, thank you, Niles, and good morning, everyone. As was mentioned, I'm Dr. Carl V. Hill, Chief Diversity, Equity, and Inclusion Officer with the Alzheimer's Association, and I'm so very excited about this morning's press briefing dedicated to highlighting scientific progress on the relationship between racism, long-term memory, and Cognition during this year's Alzheimer's Association International Conference. It's becoming more and more evident that diversity, equity, and inclusion are all fundamental to dementia science that is rigorous, meaning that research results are generalizable, representative, and relevant for all people in all communities. First, when thinking of diversity, we know that there are communities like Black, African Americans, Hispanic, Latinos who are at greater risk for developing Alzheimer's or another dementia. From an inclusion perspective, given all the pathways that scientists are uncovering, genetic factors, lifestyle factors like exercise and diet, and health behaviors like seeking healthcare to receive a timely diagnosis, it's important that the science also examines the unique experiences for those at greater risk for dementia in our society. Researchers should focus more on the unique perspectives and experiences of people, particularly those disproportionately affected by Alzheimer's or another dementia. The study of the effect of racism on cognition and long-term memory represents this intentionality, whether trying to understand structural racism and how its policies and procedures undermine people's access to quality healthcare, or interpersonal racism and discrimination at the workplace, for example, of how that leads to substance abuse and poor dietary choices during the life course that undermines brain health. The research that will be discussed today represents momentum in our pursuit for health equity, meaning that the research presented during the AAIC, this year's AAIC, is relevant for all. That the research questions are examining the factors most important and fundamental for those who have been disproportionately affected for so long. We also have an opportunity to hear about how the Alzheimer's Association is working with trusted national partners to remove barriers to dementia education, awareness, and quality dementia care, patterned by racism. The African Methodist Episcopal Church and the National Hispanic Nurses Association are all trusted organizations with presence in communities all over the country and even the world. Again, in thinking of the importance, the fundamental importance of diversity, equity, and inclusion, the Alzheimer's Association's partnerships with trusted organizations like these represents an intention to get care, support, education, and awareness to communities who are disproportionately affected, underserved, and undersupported in an equitable way. The research and practice discussed today represents a vision of how dementia science can be translated to more inclusive practice focused on intention and health equity. I'm excited to get us started. I'd like to introduce our first speaker, Dr. Jennifer Manley, a professor of neuropsychology in the Department of Neurology at Columbia University Irving Medical Center. Her research focuses on mechanisms of inequalities and cognitive aging in Alzheimer's disease. Dr. Manley.
Thank you, Dr. Hill. So as soon as my first slide comes up, thank you. I'm presenting this work on behalf of my colleagues from Columbia University. The first author is Nika Seblova, and we're joined by Drs. Avila Rieger, Krall, Adkins, Jackson, and Brickman, as well as Tiara Starks, who's a member of our research team. Next slide. Research suggests interpersonal and structural racism are contributors to racial and ethnic inequalities in health. But there's little understanding of how the multiple levels of racism, including interpersonal, institutional, and structural racism, influence cognitive aging and dementia risk. Therefore, in our project, we examine how racism at all of these multiple levels predicts memory function later in life. Next slide. We studied 1,000 and 95 community-dwelling middle-aged adults enrolled in the Offspring study in northern Manhattan in New York City. As the pie chart shows, our study is representative of Washington Heights and Harlem because our participants reflect the racial and ethnic diversity of that area. 26% of our participants self-identified as non-Hispanic Black, and almost 20% were non-Hispanic white. 55% of our participants identified as Hispanic or Latinx, but they're not a homogeneous group. One major dimension of this heterogeneity is the language that they felt most comfortable using during our evaluation. Of the Latinx group, 60% chose to be evaluated in English, and 40% chose to be evaluated in Spanish. Next slide. Another major dimension of heterogeneity in our group is the self-identified country of origin of our Latinx participants. Most were Dominican, followed by Puerto Rican and Cuban, but you can see that country of origin was distributed differently depending on language of administration. Next slide. To measure multiple levels, to measure the exposure to these multiple levels of racism in the lives of our participants, we used multiple measures. Experiences of daily interpersonal racism were measured by the Everyday Discrimination Scale. We created a chronicity score that combined reported items and their frequency. And this chart shows that non-Hispanic Black participants in orange had the highest mean exposure to daily racism compared to Latinx, who were in purple, and white people who were in gray. On average, Black participants experienced interpersonal discrimination at least once every week. Note that Black participants were much more likely to attribute these experiences of discrimination to be related to their race, ancestry, or skin color than Latinx and white people. Next. Next. Okay, good. Similarly, we combined reports of occurrence and frequency on the major discrimination scale to measure institutional racism. As the second bar chart shows, non-Hispanic Black people experienced almost 6 civil rights violations on average in their lifetime. Racism is maintained by policies and other structural factors. To represent this, we included a measure of residential segregation during childhood to study one aspect of many institutional disinvestments that reinforce racial inequalities. At least half of the Black and Latinx participants lived in segregated neighborhoods during childhood. In contrast, only about 8% of the non-Hispanic white participants did so. Next slide. We use linear regression models adjusted for age and education to examine the relationships between interpersonal racism and memory. This plot shows the beta estimates and confidence intervals for this relationship. And at the end of the slide here, we're showing the relationship of age to memory for comparison. Next. We found reliable relationships between daily experiences of racism and memory in the whole sample. The association of interpersonal racism to memory corresponds to 3 years of chronological age and was driven by non-Hispanic Black participants. Next slide. This plot has the same layout, but this time we're showing the relationship of institutional racism with delayed memory. Next. There was a reliable relationship between institutional racism and memory scores among non-Hispanic Black participants, such that each reported civil rights violation corresponded to the effect of about 4.5 years of age on memory. Next slide. This plot has the same layout. And we find that participants who lived in more racially and ethnically segregated neighborhoods when they grew up had lower delayed memory scores. This was true in the entire sample, but you can see when we stratified the analyses by group, the relationships were imprecise. Next. And final slide. The bottom line is that our results suggest that exposure to racism is a substantial driver of later life memory function, even in middle age, and especially for Black people. Everyone at this conference is dedicated to finding ways to prevent or effectively treat Alzheimer's disease-related dementias and to reduce risk factors for dementia. Our research is showing that structural racism as a chronic lifetime stressor for minoritized people is associated with poor memory in middle age. Our results suggest that efforts to increase systemic equality may also decrease risk for cognitive impairment later in life. While it's important to focus on what individuals can do to improve their own brain health, health providers need to be aware that many accumulated risks are historical and structural and not controlled by the individual. Maybe more importantly, the medical system itself may perpetuate discriminatory experiences that contribute to worse health. We want to thank the NIA for the funds to support the Offspring study, the Alzheimer's Association for their support for Dr. Seblova through a research fellowship, and especially the participants of the Offspring study.
Thank you. Our next speaker is Dr. Kristen George. She's an assistant professor of epidemiology in the Department of Public Health Sciences at UC Davis School of Medicine. Her research assesses cardiovascular contributions to dementia and cognitive aging, and she is particularly interested in how social determinants of health contribute to the excess burden of cognitive impairment and dementia among minoritized populations. Dr. George?
Thank you. I'm happy to be here to share some work on experiences of discrimination on cognitive function among the oldest old. Next slide, please. So I have no disclosures, and this work was funded by the NIA. Next slide, please. So racial disparities in dementia have been well characterized, particularly among younger old. So those are people who are age 65 and older. But we don't know very much about the oldest old, individuals who are age 90 and older. This group is one of the fastest growing segments of the population, and it's becoming increasingly diverse. But we don't know a lot about their cognitive aging, despite their high risk of dementia. And so this figure shows racial disparities among adults ages 90 and older from Kaiser Permanente, work done by Dr. Paula Gilsans. And she found that Black oldest old adults had the highest incidence of dementia, followed by Latino, white, and Asian participants. And this is pretty similar to what we see in younger old. Next slide, please. And so when we're evaluating racial health disparities, it's important to remember that racism is a fundamental cause. It shapes the social, economic, and political context that we live in, which in turn shapes our social determinants of health, our environmental exposures, and health outcomes. Next slide, please. And so this work was really to evaluate measuring racism via experiences of discrimination. And so our study question was whether experiences of discrimination can explain racial disparities in cognitive aging among the oldest old. And we hypothesized that individuals who reported experiencing no discrimination would have better cognition and less decline over time than individuals who experienced discrimination. Next slide. And so this work was done in the Life After 90 study, which is a study of all individuals ages 90 plus who are long-term members of Kaiser Permanente Northern California. This analysis included 522 participants who had a mean age of about 93 years, 63% were female, and this is a very racially and ethnically diverse cohort, which is quite unique for a study of individuals ages 90 plus. And so our analysis was run in two steps. First, we grouped participants based on self-reported experiences of discrimination, and we used the Major Experiences of Discrimination Scale, which is a validated questionnaire. We then took those groups and evaluated their relationship with cognition and cognitive trajectories over about 1.2 years. Next slide, please. So we used what's called a latent class analysis to identify 3 unique groups based on experiences of discrimination. And so participants answered questions about being denied a bank loan, having difficult neighbors, being discouraged from education, unfairly fired from a job, denied healthcare or treatment, being unfairly not hired for a job, unfairly denied a promotion, treated unfairly by police, experiencing housing discrimination, or being given poor service. We also used race, ethnicity, and gender to inform our groupings. And so we identified 3 unique groups with this analysis. The first was class 1, mostly white men who reported job discrimination. Class 2 was mostly white women and minoritized participants, both male and female, who reported little to no discrimination. And class 3 was all minoritized participants, about 50% men, and they reported widespread discrimination. Next slide, please. And so we looked at 3 different cognitive domains. The first was semantic memory, which is kind of a measure of world knowledge, executive function, a measure of organization and regulation, and verbal episodic memory, which measures our personal memories and self-concept. Next slide, please. And we found that class 1, the group that was reporting job discrimination, had better baseline cognition for semantic memory and executive function, followed by class 2 and class 3. We saw no significant differences for baseline cognition for verbal episodic memory. And then across the 3 domains, we saw that there was some decline over time, especially for semantic memory and executive function, but this decline did not differ significantly between the 3 classes. Next slide. And so among adults ages 90 plus, disparities in cognition were not fully explained by experiences of discrimination. We would have expected that class 2 that reported no discrimination would have the best cognition of the group, but we found that class 1 with that reported job discrimination had better baseline cognition in 2 domains compared to class 2 and class 3 that reported widespread discrimination. And so I think this work really highlights the point that we need to have more comprehensive measures of racism. We evaluated interpersonal racism, but that really requires the individual to be aware and report the discrimination that they experience. And there's, of course, structural racism that operates outside of any one individual, and some might not be aware quite of the structural racism that they're experiencing. And so we really need to have comprehensive measures of racism if we want to be able to understand the pathways by which racism leads to disparities in cognitive aging and dementia. So thank you. That's all I have.
Thank you. As we turn our attention to efforts to address barriers patterned by racism, our next speaker is Dr. Adriana Perez. She's an assistant professor and senior fellow at the Leonard Davis Institute of Health Economics at the University of Pennsylvania School of Nursing. Her research is focused on the influence of community-level factors on the well-being of Spanish-speaking older Latinos with Alzheimer's disease and related dementias. Dr. Perez served as policy chair for the National Association of Hispanic Nurses.
Thank you, Dr. Hale. Let's see, there we go. So today I bring to my perspective as both a nurse scientist, a nurse practitioner, seeing patients in the community and the same community in where I conduct research, testing a exercise intervention to see the effects of exercise over 12 weeks, 6 months, and a year in Spanish-speaking older Latinos. Spanish-speaking older Latinos are typically excluded from scientific research because they don't speak English. And I want to really talk about issues that already put Latinos at a disadvantage when it comes to brain health equity. So here, this is the most recent US FDA Center for Drug Evaluation and Research Drug Trial Snapshot Summary of 2021 that shows that approximately 3,300 patients were enrolled in 2 large clinical trials across 19 countries. One of the drugs that was approved that year was specifically for the treatment of Alzheimer's. 46% of patients were from the United States. 52% of trial participants were female, 78% were white, Asian 9%, Hispanic Latino 3%, Black participants were 1%, while 12% did not report their race. This is significant when Hispanic and Latinos are 1.5 times more likely to develop Alzheimer's based on many different factors, including the fact that we have higher risk factors to develop Alzheimer's. Only 3% were included. So I want to dig a little deeper too into other issues. Both Dr. Manley and Dr. George talked about the systemic barriers that contribute to these inequities of brain health. For Latinos as well, the lack of representation in healthcare is very important, meaning I don't have a provider that speaks my language, that understands my culture, both the strengths that I bring and the challenges that I experience in everyday life. That is significant. And as a nurse practitioner, every time I start a conversation with patients that are Hispanic Latino, I start in Spanish, and even though most are bilingual, most speak English, it is comforting. That in itself builds trust. So as a country, as a system, it's important to focus on where the systemic issues begin. Here you see that Hispanic workers are, we make up a large part of health aides, nursing assistants, and so people at the very beginning of healthcare occupations, but then as you go up, you see that number decrease. I have been a long member of the National Association of Hispanic Nurses, and when I graduated almost 20 years ago from nursing school, the number of Latino nurses was 5% or a little less. It's still that now. It might be 5 to 7%, but it has not changed in 20 years. And more importantly, the growth of Hispanic, Spanish-speaking nurses has not grown to keep up with the rate of growth of Latinos in this country. And the same could be said for physicians, for clinical psychologists. As you continue to look at the real critical positions to address brain health equity, we are not represented. This is going to clearly impact not just testing of interventions, of potential solutions, but also having the ability to enroll participants into clinical trials. This is from the Alzheimer's Association recent survey where Hispanics, Latinos were asked about their perceptions of clinical trials. And one of the things that they mentioned and shared is how important it is to have linguistically and culturally responsive systems, including having a provider that speaks their language, but not feeling very confident that that is the case. But there is good news. And so I also want to focus on what is happening now and what we can continue to do. First of all, memory and brain health is important to the Hispanic Latinx community. It is a priority. And for many, they feel that that is the one value that they can keep no matter, whether they have a lot of money or whether they're experiencing poverty. Having memories, that's something that keeps people inspired, motivated, wanting to engage in their health. That same survey from the Alzheimer's Association showed that Hispanics and Latinos want to take part in research. They are willing participants, but they want to be invited. 85% said they would participate if they were invited. In a series of focus groups that I conducted in North Philadelphia, when I asked participants in our focus groups about this, they said that when they see must be English proficient, even though they're bilingual or speak English, perfectly, that is a message that you're not invited. And that's how it's perceived. They want to contribute to the overall goal of research. They want to benefit from the scientific advancements because they know that this is a big health issue. And they themselves have a family member with Alzheimer's disease. There are many national efforts that are underway, including those by the FDA promoting best enrollment practices, encouraging us as scientists to think about our exclusion criteria. And you heard Dr. Manley's data that 40% of Latinos wanted Spanish. So immediately you're excluding 40% of people if you're starting with English as a requirement. So on the positive note, I'm very grateful for partnerships like the National Association of Hispanic Nurses and Alzheimer's Association, and many academic colleagues here through a study funded by the NIA. Dr. Hill, Dr. Portocolone at UCSF, and myself are leading. We're testing a community-based partnership between the National Association of Hispanic Nurses and the Alzheimer's Association, because through our research, we found that communities trust these two organizations to give them information in their language in a culturally relevant way. And we're very excited about that. So we feel hopeful for the future, despite the many challenges that we have. Thank you.
Thank you, Dr. Perez. Our final speaker is Reverend Dr. Miriam J. Burnett, a proud and a fellow graduate of Morehouse School of Medicine, historically Black College University in Atlanta, Georgia. She serves as the supervisor of missions for the 18th Episcopal District and medical director of the International Health Commission of the African Methodist Episcopal Church. She's also an ordained itinerant elder in the African Methodist Episcopal Church. Dr. Burnett.
Good morning, everyone. It's my pleasure to be with you all. Today, we're going to talk about race, public health, and faith. We're going to talk about the intersection of social determinants of health, race, and then optimal health, and then the role of faith-based organizations in trying to achieve that. In terms of disclosure, the AME Church receives some grant funds from the Alzheimer's Association for its partnership that began back in 2019. It is important to look at social determinants of health, and this statement from CDC, which you've heard pieces of, but I thought I would talk about it in its entirety. It says that race, both interpersonal and structural, negatively affects the mental and physical health of millions of people, preventing them from attaining their highest level of health and consequently affecting the health of our nation. We tend to talk about the first part of that sentence, but then don't get to preventing them from attaining their highest level of health. Many of us talk about that as optimal health. How do we ensure that racism does not impact one's ability to achieve optimal health? The Institutes of Medicine back in October of 2004 put out a report that said, entitled Unequal Treatment, Implications for Academic Health Centers. They found two factors that contributed heavily to racial and ethnic disparities in health. The first being minorities are subjected to adverse social determinants, and the third that they are disproportionately represented among the uninsured. So we're here now to talk about how do we address that? What makes some implications? What impacts optimal personhood? There's an interlocking, interweaving, intermingled relationship between economic stability, healthcare access and quality, education access and quality, neighborhood and built environment, social and community context. Take those social determinants of health, they interweave, they interlock, they circle back and forth, they mesh in different ways to be able to impact one's health. Add to that, on top of it, Now add race and racism, and one's faith and the expression of that faith. The AME Church International Health Commission has a purpose of helping the denomination see health as an integral part of our faith. And so when we move forward, this is a slide that I found when I was working on my master's of public health way back in the early 2000s, and it's still relevant today. Religious beliefs and world views jump over everything else and impact health status. Impacted by how religion is practiced, what those health beliefs and attitudes are, impact healthcare utilization, also health status. An example would be someone who has an illness needs to seek healthcare, access healthcare, and then finds that they don't want to do that because they're not waiting on Jesus to come help them. And so therefore they bypass the psychiatrist, the neurologist, and all of the things because Jesus is going to save me, rather than embracing the fact that our faith expression should embrace the fact that God has provided for us the specialists. So we have to always factor that in. So how do we get better? There's an importance of partnerships with faith-based organizations, with religious entities, that says we are going to utilize our trusted messengers. The AME Church has a plethora of physicians and nurses and other healthcare practitioners, many of which are seminary trained, I being one of them. And so we have a presence that says, this is the information that we need you to receive. This is what we need you to do next. And it's trusted, and therefore people do it. The other thing is we help to shape information that is disseminated in a culturally competent way. Linguistics is one thing, culture is yet another. And so that impacts our community outreach efforts, our awareness of support services for families that are affected and impacted by Alzheimer's and other dementias, opportunities to promote and influence dementia-related public policy. What we do know is policy and underlying policy affects everything we do. If it's not accessible, if the ability to have good, nutritious food is not there, because we know that that affects and impacts dementia, then we know that the policy that says you're living in a food desert for whichever one of the SDOHs, the social determinants of health, has caused that to happen, impacts one's ability to influence and deter, if not avoid, dementia and Alzheimer's. There's an opportunity to increase awareness and knowledge of the risks and symptoms while expanding support for Alzheimer's programming and research. It also allows for inclusion in clinical trials, because then people know what to do, how to access. The AME Church partnership with the Alzheimer's Association has done all of these things. We've just signed on for another 5 years, and that's going to allow us to address these things in a very real way. Thank you so very much.
So thank you, Dr. Burnett. Thanks to all of our speakers. High-level summary. We heard from Dr. Jennifer Manley in a study from Columbia University, Irving Medical Center of nearly 1,000 middle-aged community dwelling adults, that exposure to interpersonal and institutional racism was associated with lower memory scores. And these associations were largely driven by the Black African-American study participants. Also findings were that experiences of structural racism were associated with lower episodic memory among all ethnicities studied. Also, we heard from Dr. Kristen George in a study of Asian, Black, Latino, white, and multiracial people aged 90 years and older. And she found that individuals who experienced wide-ranging discrimination throughout life had lower semantic memory in late life compared to those who experienced little to no discrimination. And this was in the Life After 90 study. So the Alzheimer's Association believes that in order to achieve health equity, individuals and society must identify and reduce racism and other forms of discrimination. Through our diversity, equity, and inclusion efforts, we are partnering with more than 20 trusted national partners, 2 of them here today, the National Association of Hispanic Nurses and the African Methodist Episcopal Church. So we're really excited to hear about our partnership and our efforts to address these barriers patterned by racism. It's key takeaway. Racism is trauma that leads to increased stress, which we know can result in negative biological changes such as inflammation. Inflammation is a known risk factor for cognitive difficulties, including dementia. But because of systemic health disparities that create poor access to health, medication, housing, health protecting resources, those who experience racism are not provided a pathway to lower that risk. It becomes a 1-2 punch for populations that experience this type of deprivation. Racism may be a major contributor to the increased dementia risk in Black and Latino populations. And the Alzheimer's Association is partnering with trusted partners who have representation in all communities all over the country to address these barriers patterned by racism to increase representation, inclusion, and to pursue health equity for all people in all communities. So with that, we'll take questions.
In the room first?
Yes.
Hold on.
Oh, sorry.
Would you say?
Sure. Hi, Dr. Hill. Phil Guttis with Being Patient.
Hello, Phil.
So many problems with Alzheimer's and related dementia seem overwhelming. Listening to the presentations this morning, I only feel almost more overwhelmed. How do we as a community tackle so many deep societal challenges that, have an impact on Alzheimer's, but certainly go way beyond Alzheimer's?
I will certainly say that our responses and approaches should also be multi-level and should address policies that shape contextual factors, many of which our speakers discussed here today. Dr. Manley, would you like to address this question?
Sure.
Context, thank you.
Yeah, sure. So it can be overwhelming, but I think that we actually have within our data and within our lifetimes, seen ways to reduce these impacts. So one of the things that I study is schooling and how early life schooling relates to later life cognitive function. As school policies changed to increase funding and desegregate schools, but also to provide additional funding to schools that serve Black children, what we find is that this has later life implications in reducing risk for cognitive impairment and dementia. So the restriction or limitation of investment in schools that serve Black children is one example of this systemic racism, and an example of systemic equity or systemic equality is to invest in schools and neighborhoods where Black people live, where Black children go to school. And so I think, you know, it can be overwhelming, but these are things that, you know, these are policies and efforts that I think will reduce the burden of cognitive impairment for everyone, especially those people who are experiencing disparities today.
This is Dr. Burnett. One of the other things that the AME Church has taken to doing is addressing things in a multi-layered fashion. Our Health Commission has instituted farm and gardens all across the world so that high nutrition can be attained. If we can eliminate food deserts, whether it be growing food in your backyard, then we can impact dementia in a real way. And when we're impacting the dementia, because we are now providing good food and vegetables, as well as other herbs, et cetera, we are impacting diabetes, hypertension, and all of the things that make Alzheimer's, that are place us at risk for Alzheimer's and other dementias. I think that's key. The other thing is we've involved our Social Action Commission in the work that we're doing with the Alzheimer's Association. Our Social Action Commission is responsible for our public policy interventions. So it's not just us. It's involving the entire church in a very real way, to include our young people's division, so that we are addressing it at an early age in an attempt to, one, expose them so that they can take care of their parents and their grandparents and their aunties and their uncles, but also try to avert the risk that they may have.
And if I could just add, Dr. Hill, too, you know, from a workforce perspective, I think there's a lot that we can also continue to do and build upon. You know, I shared the numbers for Hispanic nurses, Hispanic Latino providers, but that's the same across the board when you look at Black, African-American nurses, providers. Those numbers are still not representative of our communities. And both from a federal perspective, private perspective, I think academic leaders, there's a lot that we can do to promote the success of diverse students in academia, starting from the very beginning and throughout, you know. So as you said, this is a complex, multifactorial issue. So we really do need an all hands in approach on encouraging diverse people to enter the field and to be able to address these issues collaboratively. Thank you.
Other questions in the room?
Are there questions on the Zoom call from journalists?
Yes.
Go ahead.
This is Ann Sidor from Practical Neurology. We report news for neurologists, primarily for practicing physicians. I want to thank the panelists for conducting this very important work, and to honor and acknowledge that, as Dr. Manley noted, the healthcare system is also a source of racism, which can make your work even more challenging. So thank you again. For Dr. George, my question is that, as you concluded, we need better ways to measure experiences of racism. Have you also thought about or looked into the need for better ways to measure cognition, considering most standardized tests have been validated in non-representative populations? Do we need to look at measures of cognitive health that are validated in a diverse, equitable, and inclusive population?
Yeah, that's a great question. And it's definitely something we definitely need better measures of cognition. I didn't mention in the talk, but the measure that we used for Life After 90 included versions in both English and Spanish, but there are a lot more ways that we can make the cognitive test more inclusive. And so I guess I would punt this question maybe to Dr. Manley, who's a neuropsychologist who might have more insights than I do as an epidemiologist.
Well, the other thing about the measure that you use that I'm familiar with is that it was designed to measure the cognitive function across these different domains of cognition equivalently across English and Spanish. We've done some work on our battery. It's statistical work. All of this that I'm talking about right now, it's sort of taking measures and then statistically making them equivalent across different groups and different languages. So there are some things you can do. And as a neuropsychologist, I think about your question quite a lot. But I think part of how I'll answer it is that I think we do have to keep the innovation and creativity up as a field. Cognition is more than just sitting across the table from someone, giving them a list of words or asking them, to draw a figure. There are everyday experiences that people are having that we're missing out on, and I think that some of the the work at this conference in among the neuropsychologists and other people who are measuring cognition that are presenting at this conference will show you all the innovative ways that they're thinking about looking at cognitive functioning in the household with cell phones that buzz you, every once in a while to assess your cognitive function, sort of these momentary assessment. So I think we need to be more creative and more culturally relevant as we are measuring our most important outcome. And so that's how I would address your question.
Thank you very much.
Any other questions on the Zoom?
Okay, well, I would like to certainly thank all of our speakers today, Dr. Jennifer Manley, Dr. Kristen George, and Dr. Adriana Perez, and Reverend Dr. Miriam J. Burnett. The research and practice discussed today certainly represents, again, a vision of how dementia science can be translated into more inclusive practice focused on intention, inclusivity, and health equity. So I'm really excited about all of our next steps and looking forward to our collaboration and work together. Thank you, everyone.